Good morning, everyone. Now, Mr. McIntosh.
Our first witness today is Professor Mike Stevens from the University of Bristol.
Yeah. Now, you say the first witness. I think he's probably the only witness.
He's the only witness, but it's always good to keep ourselves on our toes.
Morning, my lord.
Good morning. Good morning again, Professor Stevens. As you understand, you're about to be asked questions by Mr. McIntosh, sitting opposite you. But first, I understand you're prepared to take the oath.
I am.
Sitting where you are, can I ask you to raise your right hand and repeat these words after me? I swear by Almighty God.
I swear by Almighty God
that I will tell the truth.
that I will tell the truth,
The whole truth.
the whole truth,
And nothing but the truth.
and nothing but the truth.
Thank you very much,
Thank you.
Professor Stevens. We have your evidence scheduled for the morning and the afternoon. I don't know if we'll take all that time or not. We will take a coffee break at about 11:30. If you want a break at any other time, just give me an indication and we'll take a break.
Thank you very much.
Right. Now, Mr. McIntosh.
Thank you, my lord. Professor Stevens, I wonder if I can take your full name and your current occupation.
Michael Charles Garston Stevens, and I don't have an occupation, I'm retired.
And do you still hold an emeritus chair?
I do hold an emeritus position at the University of Bristol.
And what's that one?
An emeritus professor of pediatric oncology.
We've asked you to produce two documents, a statement and a short supplementary statement.
Yes.
Are you willing to adopt those as part of your evidence?
I am.
Yes. And you were the chair of the case notes review into 85 children with infections at the Royal Hospital for Children.
I was.
How did your involvement in the case notes review come about?
Well, I'm assuming that there were certain wheels turning in the background, but essentially, when I was first aware of the forthcoming case note review, it was when I received a telephone call from the then Chief Medical Officer, Catherine Calderwood, who telephoned me essentially out of the blue to discuss whether I would be interested in taking the role and giving me a brief background to the concerns that were to be investigated.
And what was in broad terms, the intended structure or methodology of this review as it was pitched to you in that initial phone call?
I don't think that initial phone call covered any structure or methodology. It was a statement of my preparedness, and I think it hinted at the terms of reference, but there was no granularity about that conversation.
When did any idea of that granularity come certainly to your attention?
Well, I mean, following that conversation, I think the next thing that happened was a telephone conference that involved Fiona McQueen, and who was then the chief nursing officer. I think that's the correct title. And then in January of 2020, I paid at least a couple of visits, one here to Edinburgh and one to Glasgow, to start to shape my sort of engagement thoughts and start to meet some of the people involved.
And how many of those physical visits happened before the other two members of the expert panel were recruited?
Well, there were certainly those two visits. I didn't meet Mark Wilcox and Gaynor Evans until what is really identified now as the first meeting of the panel, which I think was the 24th of February, 2019.
And was that an in-person meeting?
That was an in-person meeting, yes.
Could that well have been the only in-person meeting that the three of you had, given what happened 3 weeks later?
I think it was, actually. I think it was the only in-person meeting. We felt like we knew each other very well by the end of the process, but we hadn't been in the room together except that once.
And where was that meeting?
Oh, it was just along the road here. I
Right.
can't quite remember where it was. It was in a hotel, actually, in a boardroom at a
Now,
hotel.
before they became involved,
Yes.
so they must have asked you, what we're doing. How did you explain to them what you understood the nature of the piece of work to be?
Well, actually, I had no contact with them at all prior to the meeting in February 2020. the names were essentially given to me
Right.
as two other people who had agreed to serve on the same panel, which I had been asked to coordinate. And we met in a kind of round table format. And so we didn't have that opportunity for private conversations, although, after that, when we started meeting independently, we started to explore together exactly how we were going to approach our task.
But if I'd asked you at the beginning of that meeting, what's this project? What are you going to do? How would you describe what you thought you were going to do at 20th of February?
Well, I think the task for the meeting in February was to agree the data set.
Yes.
The data set had essentially been presented to us, but we were being asked to endorse it, and to talk a bit about how the data gathering would be affected, although that wasn't desperately clear at that time, and became less clear, of course, with COVID.
Of course. Who else was in the room at that meeting?
I did have a piece of paper with that written down on, but I haven't got it with me, I'm afraid. There were representatives of HPS, of Scottish Government. There were Pat O'Connor, who led what we describe in our report as the PTT team, was there. The three of us. I think I'm correct in saying that Leslie Shepherd was there, who is infection advisor to Scottish Government.
You aware of
Rains,
any
Chief Nursing Officer.
Sorry, say that again?
Phil Rains, who worked in the Chief Nursing Officer's department, was there. There were possibly about 12 of us, I would have thought.
Are you aware of whether Professor Marion Bain was there?
Yes, Marion Bain, I believe, was there, yeah.
Now, I appreciate that you're coming up from Bristol, and the nature and the structures of Scottish health may well have been a closed book to you at the time. But what job do you think Marion Bain had at that point?
My understanding was that she was part of the oversight board, and that she had been asked to take an interim role in overseeing infection prevention control at GGC. That was my understanding.
Now, one of the things that I'll come back to in the questions later is the GGC response to your work.
Yes.
But I want to just at this point, as a sort of precursor, try and understand from your point of view at that point, whether there was anybody who was in a sense 100% Greater Glasgow Health Board, either clinician or manager or clinical manager, present in those early meetings that you're aware of.
They weren't present at that specific meeting. No, right. I was aware that was a concern, and I did go back and check the membership of that first meeting, and I don't think there was no one from GGC management. In the January, I had been to GGC. I had been to.
And who did you meet in January?
I met Kevin Hill and Jamie Redfern, who were managers for the Women's and Children's, or the Children's Hospital, and I think Kevin Hill was Women's and Children's Divisional Director. I met Jennifer Rogers, who was previously the senior nurse for hematology and oncology. I met Professor Leonard. I met Pamela Ioannidis, who was infection prevention control nurse. And these were briefing meetings. I viewed them as briefing meetings.
They were briefing you effectively.
They were, yes. I had no knowledge of really anything that had gone on, or how the organisation was arranged. I had a tour of the building. I saw Ward 2A and 2B, which it was at that stage a building site because they'd already removed the patients from there. I'm just trying to remember if I met Marion Bain. I'm trying to remember if there was anyone else. I certainly didn't meet anyone at the board level at GGC at that.
Did you meet any of the hemato-oncology consultants?
I did have a meeting with them, and I think that was on the same day as my sort of exciting visit to Glasgow. I had a meeting with them. It was, they were inevitably quite suspicious of what
Yes,
we were
this
being
bloke
asked to
comes
do.
from Bristol who they've sort of
Yeah,
probably
I
never
mean,
heard of.
they weren't happy, I think, and I recognised that they'd been having a very difficult time, actually.
So one of the pieces of evidence that we've had is that in September of 2019, a number of the pediatric oncology consultants had written to senior managers and suggested an external review.
I wasn't aware of that.
Right, so it's not like they said, "Hey, great, the external review has arrived, the man we wanted." That wasn't the things you were being told at the time.
No, I didn't. I mean, it didn't feel like that I
Right.
was riding in on the white horse for them. No, not at all. Far from
One of the things I think will come up again is the extent to which those meetings in the hospital when you visited
Yes.
would have covered the nature of the methodology or the remit or the terms of reference.
No, I don't think they did. It did at all. I felt I was there to ask them questions and to understand, what the challenges were from their perspective. The issues around Ward 2A and why the patients have been moved out and what they were doing. A little bit about their infection, their IPC process.
Did you meet any of the infection prevention control team other than Marion Bain?
I met Professor Leonard
Yes.
and Pamela Ioannidis.
Right.
I can't quite remember where Pamela Ioannidis was in the hierarchy, but
At that time, I think she was a nurse consultant in the infection prevention
right.
control
Thank
team.
you.
Well, that's really helpful. What I wanted to do was to look a little bit at the choice of the cohort and how that arose,
Yes, of course.
because it seems to have come up. Now, you've discussed it in your statement. I want just basically to make sure we're talking about the right document. I wonder if we can just put bundle 7, it's document 5, page 214 on the page. It's on the screen. So this is the draft. We have it simply because it doesn't have the redactions in it, of October 2019 HPS review of GGC pediatric hemato-oncology data. Now, this document is something you've seen before?
Yes, although I have to say this document did cause me confusion from the outset because it was initially referred to as it was referred to me as a report in November 2019, and it was only very recently that I discovered there are actually two versions of this document.
Yes, if we go to page
redacted
200,
and
I think 250, we can see the next
Yeah,
version.
okay. But they're both dated October 2019.
They are, yes.
Although I understand that the redacted version was the one that was published in November 2019.
Yes, that seems to be the order of events. What's your understanding of how this document is connected to your? Is cohort the right way to describe your
Yes, you could
patients
call
and
it
your
cohort,
infections?
yeah.
How is this document connected to your cohort from your point of view?
Well, I think there are two connections. I think the principal connection is that the work that HPS did for this document more or less defined the cohort that we were going to investigate. It wasn't entirely the cohort, but they had done some work looking at several different databases, bringing them together and trying to identify the completeness of data collection under different headings, as it were.
So if we go to page 223 in that bundle, we see a comparison of a different set of data sets. Is that effectively the exercise you're talking about?
Yes.
So there was evidence from one of the production team behind this document that the effective conclusion they draw from this piece of work is that all these data sets are discussing roughly the same sort of thing that's behaving in roughly the same sort of way at roughly the same sort of time.
Yes, although I think there was also a kind of sub-message that maybe the CLABSI data set was the less comprehensive.
Yes.
But the CLABSI data set I'd always considered to be being used in GGC for a slightly different purpose.
So what was the issue that you saw with the CLABSI data set?
Well, the CLABSI data set, I mean, I think all children's cancer units look at central line associated bacterial infections. And I hope it came across in our report that we acknowledge the work that was done at GGC to drive down the incidence of CLABSI infections. But that's largely focusing on an entirely different group of bacteria. It's focusing on gram-positive bacteria because the commonest cause of central line-associated bloodstream infections relates to staphylococcal infections. And these are commensals on the skin and very readily get into central line, the intravenous access, semi-permanent intravenous access that these children
And
have.
it's possible in a unit which has that problem to take steps to reduce those by improving practice, in essence.
Yeah, just improving. I mean, there's some basic IPC stuff like hand washing, but there's some more technical things like the dressings you use to put over the site of the central line and so on. And and I think GGC did a great piece of work in looking at those issues. They had a working group, but although they claim that this reduced the incidence of infection, the infections that they reduced were not the ones that we were interested in.
Yes, I mean, well, one of the questions that does arise is why this cohort, and of course this cohort includes people, so one has to be sort of like careful about treating it as an object.
Yes.
But why this cohort was the right cohort to look at? Because we know that obviously the minister made an announcement, there shall be a case notes review.
Yes.
You were appointed to lead it.
Yes.
In what sense do you feel sufficient thought was given to the question of whether this cohort was the right cohort to look at?
Well, my understanding and my belief now is that this was the right cohort because essentially there was clear concern at the time we were appointed about the water system in GGC. And I think there's greater clarity about that now, but that's certainly out with my expertise. And so we felt that that in order to explore the potential for environmental transmission of infection, you needed to be looking at a group of bacteria that essentially liked wet environments.
Yes, these are the ones you described.
These are the wet ones.
Yes, the gram-negative environmental bacteria.
Yes, yes.
And
but it includes, of course, also some bacteria which are described as enteric. That's why the label is sometimes gram-negative environmental enteric, which are bacteria that also, are routinely found in the gut, for example, like Klebsiella.
Yes, I'm going to come back to Klebsiella. Well, I mean, I can probably do it now usefully. One of the issues that seems to have arisen in this inquiry is how does one tell whether an infection or a number of infections happening in roughly the same time frame are enteric, that are somehow broken through from the gut, or have come from another place, for example, water. The patient is
Okay.
And I'd be interested to see what, in a sense, you would be looking for if it was an enteric. If you had an enteric case, how would you spot that compared to an environmental as a clinician treating the patient?
Well, I think it's important to preface the comment with there's no perfect measure. There's no test you can do to say this is an endogenously within the patient acquired infection versus an external infection. But the things that you would look for are some of the common complications of patients receiving chemotherapy, which are evidence of damage to the mucosa of the gastrointestinal tract, starting at the mouth and going to the anus, essentially. But children with severe mucositis, that's ulcers and soreness of the mouth and throat. Patients who develop abdominal pain. Sometimes, in severe infections, abdominal distension. Sometimes it's a radiological change or that suggests that there is serious inflammation of the gut mucosa, diarrhea, and so there's a constellation of clinical of clinical signs and symptoms that you would look for, and which we did routinely try to ascertain from the case notes in relation to making that judgment. Is this Pseudomonas infection likely to have arisen because of severe damage to the gut, or actually could it have come from the environment?
Right, we'll pick that up in detail as we go. What I wanted to do was look at the epidemiological protocol, which was produced, which I understand you might have seen at the time.
I have.
So this should be now in Bundle 27, Volume 6, Document 24. That's the one. So this, what is the? When did you see this?
I probably saw it on the cusp of January, early February. It's dated February. I don't know which day in February, but there was a certain amount of email transmission because prior to the meeting at the end of February, the big roundtable meeting when we all got together for the first time, I was involved in a dialogue with HPS, representatives from HPS, facilitated by Phil Rains, who was the sort of the operating officer for this process, about the data that we would be needing to collect to inform our work. When I saw this document, I wasn't entirely sure that this was what I had in mind, I suppose. There's a rather large appendix to this document.
Yes, there is.
Which I didn't feel was informative.
Right.
As far as I was concerned, in terms of what I was looking for.
But could in some ways it be described as a sort of shopping list of what data you wanted and a plan of how to deal with it?
Yes, I had already actually started to write my own list.
Right.
And so I produced a list and they produced a list and I think we moved forward, perhaps not smoothly, but in steps to identify what it is that we wanted. And then the next step, of course, was how were we going to get it?
Well, indeed, because without going through the document line by line, most of the data is GGC data, patient data, health board.
Essentially, it's all GGC data as far as I'm
concerned.
So,
from your point of view, this is an epidemiological protocol that you've been involved in producing with people from HPS.
Well, I didn't produce this protocol. No, this.
But you read it.
I read it, and I'd got my own list, and I think I'd already sent in a list saying, "Well, this is what I want," and there were things they were suggesting, and I was a bit surprised about, perhaps. And also, I didn't understand at the time that HPS was going to have a role in extracting some of the information that they identified, like antibiotic doses. But in fact, they were able to do that. And so we eventually teased out who was going to provide what. And in the end, it didn't matter as long as I got it.
Well, I appreciate that. But one of the things that's slightly thrown us is that it's our understanding, that you can comment on this, that this actual document might well never have been shown to Greater Glasgow and Clyde Health Board.
I've no idea.
And I suppose this is the moment to pick up and explore the privacy data of what you had and how it was ultimately distributed.
Yes.
So you collected in a lot of data almost entirely from Greater Glasgow.
Yes.
You conducted a process, which we will discuss in a moment, and your outputs are what? The overview report and 85 individual patient reports.
Well, I think there's three outputs. There's the overview report. There's the what we call our data synthesis.
Yes.
And there are some templates you may.
And that's at the end of the overview report.
At the end of the overview report, which is how we collated, managed, and interrogated the data, and then there was the direct correspondence with the parents. And that was when we wrote to every family with our interpretation. We didn't just send them our data synthesis. No. We sent them certain extracts and we put some narrative around it and also offered them support and the opportunity to meet us. And then finally, for a selected group of patients who requested meetings with us, there was further correspondence.
And in that correspondence with the families,
yes,
what was the who was to see that correspondence other than the families?
No one.
No. And what was the reason for that, as far as you understood it?
Well, I think it was made very clear to us, and to be fair, I can't be absolutely sure whether it was an edict or a sense that I acquired, but it was made very clear to us that the parents of the children concerned had a pretty difficult time in terms of understanding what had happened to their children and what indeed had happened to the service on which their children relied. And it was clear to me, to us as the three of us, that we were undertaking this task for those families, in large part, not only for those families, because other people were going to see our report, but we were encouraged, and I believe rightly, we were encouraged to assure families that that the details of their child's individual journey through these infections was not going to become public knowledge unless they wished it to be. Now, that did create some difficulty with the clinicians who said, well, you know, how
This is the clinicians in the
Yes.
hepatology clinicians.
Yes, and you know, I mean, I can understand their sense. They were saying, well, you know, how can we possibly respond to this unless we know? And you know, we agreed, and that we would encourage families to allow us to give their permission for us to share the information with their treating consultants.
And in sort of very broad terms, was that an offer that was taken up or not?
It was about a quarter of the families. I mean, I do, and in fact, when I was preparing, I realised that there's possibly a document that the inquiry doesn't have, which was a final report, because I've not seen it in any of the bundles, and I should perhaps have brought it to your attention. But there's a final report I wrote to the Cabinet Secretary.
Oh, well, no, we're very interested in that.
In July, at the end of June, where we essentially said we've now finished our relationships, our communications with the families. We've met families, and this is the upshot. And we summarised what the feedback from the families was, and we also attached to it a redacted sample of a letter to a family to give some idea of
Would
what
be of
the
assistance
families
to have that.
received. And I do apologise. It was only this week when I realised that possibly that I don't quite know how that hasn't
Right,
gone to you.
will we also check that we haven't inadvertently not
Okay.
included as well? But the question I wanted to ask that arises from that is, obviously you produced your report after this inquiry was set up,
Yes.
and from the inquiry's point of view, your conclusions are certainly of interest. That's why you're here giving evidence.
Yes.
But also, we've noticed we'll come to them later, the comments that were provided by Greater Glasgow and Clyde to the draft that you sent them
Yes.
a month or so before publication. To some extent, is it a fair observation that to truly understand the reasons for your ultimate conclusions as to the likelihood of links over the whole 85 people, you'd actually have to read all 85 individual, at least data summaries, if not the letters to the families, to truly understand the granularity, as you put it, what's going on inside. Is that a fair comment, or am I?
No, that's absolutely true. I think the letters to the parents would add a dimension, but essentially what you would need to do is look at our data synthesis outputs, and try and follow the reasoning by which we allocated different levels of potential.
Well, I'll come back to the reasoning,
Okay.
but and I'll come back to Greater Glasgow's response to your draft, because I think both of those are related.
Yes.
So what I want to do is to look at the report itself, which is on bundle 6, page 999, and your term of reference, just to sort of wrap this bit up.
Yes.
So you set out the term of reference in this section. Now, what you don't actually do, which is the slightly strange thing, if you don't mind me saying, is just write out, cut and paste in a term of reference. You almost read as if you're summarising it. Is that a sort of fair critique of this part of the report? Is there an external document that we haven't seen that sets out a term of reference? Dear Professor Stevens, please do X.
Yes, no, there is a document. There is a document that sets out the terms of reference,
Right.
which is reproduced here, and I think it says at the top of
Page 100.
yeah, page no, at the top of this page that's on the screen.
Yes.
It says this chapter presents the terms of reference as written for and agreed by the core project team and the oversight board in March. But we've added notes. It says to indicate where
Right.
we've made important adjustments. So essentially, these are the terms of reference. We didn't tamper with the terms of reference. We had an opportunity to comment on them before they were finalised, but these are the approved terms of reference.
So how would you describe the task you were asked to do? You've gone through all the process. You've had the meetings in January. You've had the roundtable meeting. March, we went to the pandemic. This has been agreed. If you, not that you'd have met anybody at that point, but if you met somebody at that point and said, what are you up to? In simple terms, what were you being asked to do?
Well, if someone had said, I've got one patient, I'd like you to look at it, I would say I'd do a root cause analysis.
Right.
If you've got 85 patients, you have to do essentially 85 root cause analyses, and then you have to write a report that synthesizes 85 root cause analyses, and I think that's what we tried to do.
And when you see a root cause analysis, clearly you've discussed how you had access to, you looked at the medical records in
Yes?
the report. And we've got all the other pieces of data listed at section 11 of your overview report.
Yes.
And Ms. Evans has described yesterday in some detail looking at water testing results, looking at maintenance records. The report describes looking at cleaning records, IPC audits.
Yes.
There's discussion, which we can come back to, about the role or absence of a role for whole genome sequencing in this exercise. But one thing that seems to be missing is a comparison between this unit and what was going on in Ward 2A and the Shahadin unit from 15 to 19 with a comparable unit elsewhere in the country. And I wondered, we can talk about the merits of that later, but why is that not within something that was set out as part of the term of reference?
The short answer is I'm not clear, because the terms of reference were, I think, essentially the terms of reference were the Scottish Government's terms of reference.
Right.
My second answer is that the HPS 2019 report did make an attempt at comparison within Scotland,
Yes.
looking at the other units. And my third answer is that I did not know then, and I do not know now, how you would acquire that information, although Mr. Mukherjee clearly did by a Freedom of Information
Well,
request.
I'll come back to that after lunch, I think.
Yes.
Right, what I wanted to do then is to think about your methodology, because you've discussed it from page 121 of your statement, or paragraph 157 of your statement. But probably the best place to look, is actually page 1015 of bundle 5. Bundle 6, sorry. I was entirely misspoken on my part. $10.15. Now, what I'd like to do is to not spend too much time on this seemingly quite complicated flowchart, but to use it to go and look at the documents, templates at the end of the document.
Yes.
And perhaps see if we can understand how you carried out these individual 85 root cause analyses.
Yes.
We've had some evidence from Professor Wilcox and from Ms. Evans already.
Yes.
But so within this flowchart, figure 3.2,
Yes.
can you explain the process? Because it does feel like one of those flowcharts where every box is connected to every other box. So what's happening inside the blue box?
Well, I think the blue box
Which is-
essentially
yes.
was work that we had direct control of, I suppose. There were people within our wider team collecting these data. What's inside the red box is broadly the information, well, in fact, entirely the information that we requested from GGC or other sources.
It's effectively the information listed in the epidemiological protocol, or your original list.
Well, it certainly includes, I mean, without going back and looking at that protocol, it certainly includes what's in that protocol, but I think there's more in here.
Right.
Than,
So that's
than
so
would have been in
basically
there.
the red box is principal data sources, and the blue is the process.
Well, the blue is both the process and the collection of some pretty basic information about the nature of the child's illness, the dates of admission, the
Yes.
dates of the infection, the dates at which the child moved around the hospital, and you may want to get into the detail about how we knew all that.
Well, I think it'd be helpful. What I'd like to do is start, if that's the right place to start,
Yes.
with what you're taking from the child's medical records themselves.
Okay.
And that seems to involve the PTT team.
Well, it did. I mean, it only involved the PTT team because of COVID, because, I had envisaged that as the clinical member of the case note review, I would probably have to spend some time reviewing case notes myself. And
Literally in Glasgow, probably.
literally, and that was my expectation, that I
Yes.
would be coming to Glasgow and getting access to case notes and extracting the clinical information that I perceived to be relevant to the episode of infection for each child.
And so, obviously, you weren't able to do that.
I wasn't.
But if you're doing that exercise 85 times, how do you ensure that you're consistently looking for the same sort of events and information in a set of medical notes 85 times?
Well, by having a pro forma, which I think is what you see as one of our appendices.
Well, let's look at the appendices. So we'll go to,
Appendix D, Part 1, the data set.
yes, so that is on page 1109. So what would be helpful is if you could, well, I don't do every line, but give us a feeling for the sections, why each section is there, what purpose it's serving in the collection of this data set. Obviously, the other is easy to understand, but
Yes, I mean, some of the labels in this pro forma relate to the way that these items were organized in previous versions. I mean, I think
yeah,
that the labeling is other is a slightly odd. It's identifier, I suppose. Gender, date of birth, and so on. We wanted to know something about the child's cancer diagnosis because that would then give us insights into the intensity of treatment, the type of treatment, the duration of treatment, and the risks of that treatment.
So effectively, treatment protocol is going to be quite information heavy.
Yes, the way children's cancer care is organised in most developed countries, and certainly in the United Kingdom, is that wherever possible, children with the same diagnosis are treated on the same protocol throughout the country.
Right.
So that in Bristol, I would be treating a child with acute lymphoblastic leukemia in exactly the same way as a child with acute lymphoblastic leukemia is treated in Glasgow.
So if you knew what the protocol, if they just described the protocol there, you would know what it was. You wouldn't have
Yes.
any translation errors.
Yes, and now that protocols are not simple documents,
No.
and there's many different avenues you can go down. But in terms of a sense of overview, I would know instinctively the burden of therapy, the complexity of the therapy, and some of the nuances of decisions that might have to be made to change therapy.
And if there was a protocol being applied to a patient that you hadn't recently dealt with in Bristol, you would be able to look at the protocol and pull out that information from it.
Yes, I mean, so a child with a kidney cancer, Wilms tumor, I would know. I mean, I would know what the approach to treatment was, both in Bristol, London, Leeds, Glasgow, Edinburgh.
Right.
There's a national organisation that coordinates between children's cancer centres.
Okay. And then in terms of the delivery of the treatment in the past 30 days, what sort of data will we find in there? Because that possibly is quite a detailed box.
That was actually quite hard, I have to say, that the detail of that, what we were probably looking for most was whether chemotherapy in particular, or perhaps radiation, but less frequently, or surgery, had been initiated, utilized in a period of time prior to the infection. 30 days was an empiric margin. We considered that was a sufficient period before the infection for any treatment variation or any treatment implementation to have had an influence.
So effectively you're looking for a treatment that might have had an effect that you need to take account of in this thought process.
Yeah, I mean, if a child had a major operation 2 weeks before the infection, particularly, say, for example, if it involved the gut, that would automatically raise for me a question, well, could that intervention have had an impact on the cause of the infection?
Right. And then in terms of microbiology.
Well, and the microbiology, essentially the microbiology was delivered to us by HPS, actually.
Right, so
we
that
didn't
comes out of
extract
HPS.
that. We didn't extract that from the case. They extracted that, and they presented it to us, the nature of the infection, genus and species. There's a small point there under item 12 about category for inclusion, because there were actually, I mean, it's a sort of slightly subtle point, but there were 3 groups within within the cohort. There was do you want me to expand?
Please do.
Well, there was the largest group, which are the children with the gram-negative enteric, environmental enteric infections. They were the lion's share. The second group were the 3 children with Mycobacterium chelonae. And the third group was, it had been left open that a family could ask for their child to be included in the case note review if they wished. And there was one family that asked to be included, because that child would have been excluded because they didn't have evidence of a bloodstream infection. It was a child who had a Pseudomonas infection, in fact a very severe Pseudomonas infection, but never had a positive blood culture.
I see.
But had multiple cultures of Pseudomonas from other sites.
Right.
And so that child was included, even though the patient didn't fit the criteria for the selection to the cohort. So there was that one. So we still reviewed that case.
Yes.
We made a judgment, and we provided the information to the family.
And so, apart from the category item 12,
yes,
all these other rows in microbiology are A, provided by HPS, and are B, presumably just pulled from the records of the hospital, and they all refer to that particular patient. They're not telling you the context in terms of other infections nearby. That comes elsewhere.
Yes, that comes elsewhere, which I can talk about now or later.
We'll get on to it. Let's look at the infection episode.
Yes.
Again, a lot of data here. How is this being pulled into your process?
Well, some of this came from the HPS team. So, for example, admission dates they were able to provide. They were able to provide ward and bed locations to us. But most of the other stuff within this section was from data extraction, sort of crude data extraction from the clinical record.
And this will involve the pediatric trigger tool, to some extent?
No, it doesn't involve the pediatric trigger tool. I think it's probably quite important that we're going to come to that conversation.
We're going to have a conversation. Let's get to the end of this section, and then we'll pick up that delicate topic of confusion.
Thank you.
So most of this is coming from the medical records, and this is effectively what you would have been doing, sitting in a room in Glasgow if there hadn't been a pandemic, probably.
Yes, or I would, once I realised the scale of the task, I probably would have got someone to help me too. And in fact, I did have someone who helped me. I had a paediatric trainee who worked with me to extract some of this data.
Right.
And
Let's have a topic conversation about the pediatric trigger tool, because there has been some confusion. As I understand it, some people thought that the pediatric trigger tool was deciding whether the case was going to be in the cohort. I mean,
No.
that's not right.
No, not at all. I think I've made clear, but I'll say it for clarity now.
I think so.
I didn't understand why we were obliged to have the pediatric trigger tool as part of the case note review.
Right.
But it had been decided that we should.
Somewhere, presumably within HPS or
No, not within HPS. It was within the Chief Nurses Directorate of the Scottish Government. In fact, I think specifically it came from Diane Murray, who was the Assistant Chief Nurse.
Right.
It was felt that this was an opportunity to use a well-defined and accredited tool to look at measures of potential alerts within the care of patients to identify whether there could be lessons drawn by the organisation for future improvement of healthcare. And that's a motive that's very noble, very valuable, but I didn't see personally how it lay alongside what we were trying to do.
So in a sense, it's slightly contradictory in that your exercise we're looking at here is about pulling data.
Yes.
You're spotting when things have happened, when they happened, what happened.
Yes, and but that's the data I'm interested in. The trigger tool is looking across a whole range of markers, and you can see in the appendix there's a template for the trigger tool.
And so, am I right in thinking, therefore, from your explanation, that the purpose might have been that use of the trigger tool would enable lessons to be learned about when in the future people should be alert to these
Yes,
sort of
I did.
problems?
But the trouble is, I did have difficulty with some of the domains within the trigger tool, because the trigger tool has been defined largely within general paediatric populations across a range of patients. And so,
well, we can just briefly look at it. It's 1107.
Yeah. So, I mean, perhaps I can,
There's a couple of ones that sort of stand out. If we go to 1107. And maybe we zoom into half a page because it is awfully small.
Yeah. Well, if you look at PL15, for example.
Go to the bottom half of the page, please. Over the next page, actually.
It may be on the next page.
In fact,
PL15,
it's on
go
1109.
down. Yeah. PL15, thrombocytopenia. This is when the level of platelets are low in the blood. And this trigger tool would be flagged as positive if the platelet level was less than 100.
Yes.
Now, that's such a routine occurrence when you're giving chemotherapy. Quite frankly, it's of no merit. It just is unimportant. PL2, giving a blood transfusion, we give blood transfusions all the time to children having chemotherapy. So the specific relevance of some of the triggers, I'm not saying it negates the whole exercise. All I'm saying is that some of these things didn't strike me as being triggers at all, because they're innate to the whole pathway of care.
Yes. So I am putting words in your mouth. I'll put it to you. It's effectively a distraction in some sense.
To be absolutely honest, I felt it was a distraction, but, and this is the silver lining, I think there were 2 points. First is, without having formed the team that were going to do this work with Pat O'Connor and Peter Davey, and there were others, but they dropped out because of COVID, but there were others who were going to be involved. Without having that team, we didn't have anyone who was equipped to interrogate the case notes for us.
Right.
So essentially, I said, please carry on, do your trigger tool work, because it does have some intrinsic value of its own. It just didn't inform our terms of reference.
So effectively, it becomes a checklist.
Well, it was a checklist.
So you're noticing if something's on the trigger tool list, when did it happen? That's a fact we want to know. Is it boiled down to that?
I didn't want to know. A lot of what's on this list I didn't want to know.
I see.
you know, so essentially, Pat O'Connor and Peter Davey were collecting data, which actually turned out, I believe, to be quite valuable, because what they were able to demonstrate was the good news for GGC was that the rate of adverse events identified by the trigger tool was no worse for GGC than it was for other children's hospitals. So
Right.
that's a marker of sort of, you know, it's a benchmark for
Of general care and general
yeah,
process.
absolutely. But the other thing it did identify, which was I felt more germane to our work, was that GGC weren't using their own internal DATIC system for reporting adverse events as effectively as they might have done.
Right.
And that was something that we did look at. You know, we looked at adverse events and we made a comment on that. I wouldn't say that was a major finding of our report, but it was there. So yes, to be blunt, the PTT was a distraction. The silver lining was, by having the team who were going to do this work, we were able to actually ask them to extract the separate template of data that we need for the case.
Which is the one we just looked at in the appendix.
And the third thing, of course, is that it produced a worthwhile output, and they produced a separate report to the oversight board, which then somewhat disappointingly didn't seem to get progressed or published.
Well, indeed, that's one of the questions that's been suggested I should ask you, which is why, as far as you understand it, was the PTT report, which we've put in a bundle,
Yes.
not issued to published?
I don't know.
Were you ever given a reason?
No, and it was a task for the oversight board, and as we were completing our review, not only was there a Scottish Government election, but there was a change of personnel within the oversight board, and so it kind of falls for me into the same basket as we made 40-odd recommendations, and I don't know what happened to those recommendations. So
well, I'll come back to the recommendation.
Publishing the PTT report, and you know, it's useful information for GGC. It wasn't innately particularly critical of them. It demonstrated some very useful points, I thought, and I thought they should have been given it.
And the version that we've been able to comes from you. We didn't get it from anyone else.
I had understood that finally the PTT report had been published and made available through NSS Scotland, but I don't know.
I'm sure someone will correct me.
It should have been made available. It could have been usefully made available to all children's units in Scotland. It could have been
because the PTT data is being collected across all units, so you can do a comparison of PTT triggers.
Yeah, and in fact, if the literature behind the PTT is that this is a template that can be used in the care of children in lots of different settings.
Right.
But it's, I mean, I hope that I've clarified that the PTT issue itself is not directly relevant to the findings of the case note review. It's a bit of a bolt-on.
Right. Well, let's go back to page 1109, because
Can I just clarify for my own purposes? Going back to the beginning of what you were saying in
Yes.
relation to the PTT, I think I understand the point that the PTT is designed for many illnesses. I mean, it's not specific
No,
to pediatric cancer
no,
care.
it's not, absolutely.
And a result of that is that it will note as an event of significance something which is routine in cancer care.
Yes, absolutely.
But it is a way or a tool, a method for interrogating the medical records of a child.
It is, and some hospitals use it. So perhaps on a monthly basis, they might select 10 case notes at random, and apply the pediatric trigger tool to the admission, just to see whether it identifies issues that perhaps weren't adequately addressed or might have contributed to better management of the patient. So it can be used as an audit tool.
Can be used as an audit tool. Correct me if I've got this wrong. When you, from your particular perspective as an oncologist, are looking at the record of a particular child,
Yes.
I'm supposing that the exercise that you're carrying out is a similar sort of exercise as the application of the trigger tool is designed for. In other words, looking at medical records for events which you consider are significant in the history of that particular child. Or have I got that wrong?
No, I think that's absolutely right. Essentially, I hoped I knew what I was looking for in the patients who had infection. The trigger tool provides, as it were, a pre-prepared template that you can apply to a hospital admission for a child with any condition. And you know, that's its value in the sense it can be used as an audit tool across a range of pediatric hospitalizations, and it can be readily used in different settings for comparison.
And did I hear in your own, excuse me, in your answers to Mr. McIntosh, that when you were interrogating or rather, the way you set about interrogating the records of the children, your team was, or maybe you were, looking at records having regard to a different list of significant events, or did I misunderstand your answer?
No, I think you're correct, my lord. We created our own list of data that we wished to collect, and there wasn't really overlap with the pediatric trigger tool. Some of the things that are within the trigger tool we would have expected to be happening in the patients, and anyway, and therefore were of no great concern to us because they're predictable.
Right. So there was, as it were, a separate list.
Yes.
Which was informed by events which you considered, from your expert perspective, to be of significance.
Yes, and that's what's on the screen, essentially.
So we put 1109 on the screen, please.
Yeah, right. Thank you. I just wanted to make sure that I'm keeping up.
That we just looked at above, in the middle of the page, rather.
Yes.
That infection episode list, ignoring the title, for, as you said, that list of events, in a sense, is that where we find the things that you thought were important?
Yes, absolutely. I mean, this is the framework around which we were looking to see, was this a child that had been admitted for perhaps a routine course of chemotherapy, was well on admission, but 3 days into the admission developed a fever and was found to have a bloodstream infection? Or was this a child that had presented to the day unit with a fever, was unwell, and was found to have an infection?
Those would be two very different possible sources.
But they could be two very different possible sources, but no doubt we'll come back to that.
And then things, for example, we look at that infection episode section.
Yes.
I'm assuming place admitted from would include home, other hospitals.
Yes, absolutely.
Right. And reason for admission, again, might be planned, might be
planned, or it might be mum says he's not been so well.
Yeah.
Had a temperature breakfast time. It might be something very mundane, but it gives you some idea of the trajectory of the illness.
And then the date of onset would matter because of that traditional observation that sometimes infections that occur with only 48 hours of admission might not be hospital acquired. But
yeah, date of onset. Date of onset. So a child who was admitted on Monday, who had a temperature on Wednesday, the date of onset symptoms was the arrival of the fever on Wednesday, even though the child was admitted on Monday for chemotherapy, for example. or it could be a child who comes from home when the mother said, well, actually he's been off colour and complaining of tummy ache for the last 36 hours.
Right.
So date of onset is pretty imprecise actually, but you estimate how long the child may have been unwell.
But if you're trying to distinguish, so one of the things that we had yesterday, and maybe I should pause this bit and look at the definitions of the conclusions you reached and then bring it back to this. So yesterday we had evidence from Ms. Evans about the definition of possible and probable. And we had evidence from Professor Wilcox about the number of different categories and whether perhaps there were too many categories originally chosen. And what I wanted to do was to, just as an aide memoir to this conversation, I'm not so much asking about the outcome, but the categories.
Yes.
To go back to, I think it's figure 4.2, which is on page 1043.
Yeah.
So we'll come back to what the categories were, what the outcome was later. But we were pressing both Ms. Evans and Professor Wilcox on what these all meant. And they've seemed to have given us quite a solid explanation of what unrelated means. But what do you think unrelated means?
Unrelated is a small number of episodes of infection where we were convinced that there was another story at play.
And what sort of stories would those be?
Well, there's one very clear example of a child who actually didn't have cancer, had another kind of serious blood disease, nevertheless required repeated intravenous treatments, who presented 3 times with a very unusual infection in the bloodstream. And this was, and I'm embarrassed to say I can't remember the name of the bug, but it will be in one of these lists. It's a very unusual organism to be found in a hospital setting. It's a bacteria that is known sometimes to be associated with soil and external environments. And the occurrence of this infection 3 times in a child who was having a lot of intravenous treatments given at home.
Mm-hmm. Right.
Given at home meant that we didn't have a great deal of difficulty in saying we didn't think this was to do with the hospital environment. And in fact, the treating team of that child had already drawn the same conclusion, it turned out, and had suggested that there should be water sampling from the home environment.
Right.
In fact, it may be that it features in the report, actually. I'm not sure.
But if we move into passing delicately over weak possible for a moment, if we look at possible.
Yes.
What does possible mean?
Well, possible, I think, means that this was an infection with a bacteria that is found in the environment, because that's how we selected the list, where there was no evidence that we could see that this was an endogenously acquired infection. So there was no apparent gut or mouth
The symptoms you discussed a few minutes ago.
No gut or mouth symptoms. That there wasn't, for example, signs of inflammation around the central line exit site. There was no other sign of infection.
So that would have put it in a CLABSI gram-positives possible.
Well, I mean, a gram-positive is the most likely, but just occasionally you take a swab of an exit site of a central line and you find something different.
Right.
But most typically it's a staphylococcus. So there were none of those things. So we were left with a child who'd got an environmental infection in the bloodstream with no other apparent cause. That became possible for us as a link to the environment.
Okay,
but it wasn't supported by the finding of any environmental cultures or bacterial typing.
Would it have been associated with a other similar infections in the same time and place, or is that put in?
No, and
higher
I think,
category?
and that's an important point, and I should have said that that in terms of our ability to look for clusters, and you might want to bring me back
Yeah,
to
I will do.
because to tell you how we did that, but there were no apparently or potentially correlated infections in terms of.
So a possible is we've not excluded, but we think we've excluded obvious enteric gut-related
Yes.
infections, and we think we've not seen signs of a gram-negative in the central line,
Or any other kind of
Or any-
infection, no urine or ear
Yeah.
or
So those all aren't there.
Yeah.
But at the same time, we've not found a cluster, and we've not found an environmental sample. We've not found anything else.
Yeah, or we found a similar organism that occurred 9 months previously. Within the relationship is so weak that we wouldn't.
Same ward, but different year.
Yeah, but
Right. So before we go back to 1109, I want to just look at weak positive and weak possible. So how does something drift down from possible to weak possible? I get that Professor Wilcox's slight despair at the possibility of having too many categories.
Well, when I revisited this in my preparation for today, I wondered whether we'd tried a bit hard to get granular, because essentially, and I think we do make this statement in our report. This is not a binary decision. It's not, this is related to the environment. It's not. Would that it could be so simple. You could just say yes or no. You can't do that. You're working on a gradient of probability. And, we could have had a linear analog score. We could have said it goes from 0 to 10, and we think this patient's about a 6. But I don't think that would have been very helpful, because we would then have to define what a 6 was.
Yes.
And so I think this was our attempt to show the gradation of confidence in terms of unrelated to definitely related.
So
You see, we never got to definitely related.
With a weak possible, what sort of things would cause something to slip from a possible to a weak possible?
I think a weak possible would be a patient who perhaps had very infrequent contact with the hospital. Perhaps had not been coming to daycare very frequently. Some patients come 20 days in a month to daycare, and they have their central line accessed all the time. Some patients, might not have been seen for 6 weeks, and so the pattern of contact with the hospital, I think, would have been
So there's sort of value judgment in there about.
Yeah, I think there's a and that brings us into the territory of how do you what's the best denominator for infection
We're going to
rates,
do that this afternoon.
and I think the frequency with which you represent to the hospital presents a measure of risk. So a patient that's only come once in 6 weeks compared to a patient that's, say, come 6 times in 6 weeks, there's a difference there in terms of the likely relationship to the environment.
And in terms of the drift up, it's a very small number from possible to strong possible. What's the sort of thing what sort of things are pushing people into the strong possible category?
I think it's almost certainly related to clustering, actually. Without going back and looking at those 4 patients, I wouldn't be able to answer that.
I'm going to leave clustering and come back to this table, but I want to go back to 1109 to ask you a question about Appendix D.
Yes, in retrospect, I think putting a strong possible in was probably not very helpful. It was very
If
small.
we just put the middle of the page in, just the middle of the page. What I wanted to understand is that we just discussed information you would use to put something into the unrelated category, and we discussed information that you would use that you would look for and not find for it to be in the possible category.
Yes.
To do with enteric and lines and ear infections. Where do we see in this template structure the sort of information that would enable you to exclude things from possible?
Well, it really comes under 22, I think, 21 and 22. Reason for admission, date of onset of symptoms. It wasn't just that we wanted a date of onset of symptoms. We wanted something about the evolution of the symptoms.
Mm-hmm.
So we wanted to know what the trajectory of that illness was. Was this a child that turned up at the day unit who was, ostensibly for some routine aspect of therapy, it wasn't done well, but had a slight fever and a temperature and a culture was taken? Or was this a child who actually presented, catastrophically sick and ended up going to the intensive care unit? And so that additional information was built around those two data lines.
So if we were to look at one of the patient's entries for those two data lines would be quite full of information. It wouldn't just be a date. It would be quite a lot of narrative at this point.
Yes, and if I might ask, if you move to the next slide of the
Yes, of course.
Of the template,
We can just jump out and move to the next slide, please. Next page.
this summary,
Yeah.
I did worry both then and now how we could have better illustrated the depth to which we went into the clinical circumstances of the infection. But many patients, if you look at the white bar where it says there's a blue bar at the top which has got the unique patient number, the date of the episode, the dates of the panel review.
Yes.
If you look under that, it's got clinical timeline, and then there are some unshaded white lines, and so in there we've got dates and events. Well, many patients would have had a complete page of
Right.
narrative of dates that extended over a period of maybe 2 to 3 weeks, and sometimes much longer than that, indicating something about the date of onset of symptoms, the date of the admission, the date at which the culture was done, the date at which the culture was reported, the date at which another culture was done, the date of an evolution of symptoms, the date at which the child went to intensive care, the date at which chemotherapy was subsequently re-established. So there's a whole narrative, and I realize now that this page is a rather poor representation of, and that's why we did submit to the inquiry two worked examples of a relatively simple case and a more complex case. But it's difficult to make these things public documents.
Yes.
Because every child's clinical course is a footprint, essentially.
Of course. And that's why they're not in the bundle. So
No, absolutely. But perhaps you've had an opportunity to look at them and to understand the approach that we took.
And I thought might be helpful, because obviously this is a public inquiry, and my colleagues here and the public have to understand what we've done.
Yes.
Is to see what this exercise, if we can go back to page 1109 so I don't forget, this exercise compares to other things. Now, obviously, you're now retired, but you were a treating clinician in the Bristol
Yes.
unit. If there had been a single case
Yes.
or a small cluster of gram-negative environmental infections in
Yes.
your hospital,
Yes.
there would have been an IMT, I'm assuming.
Well, the system isn't labelled quite the same way.
But a similar thing would happen. There would be
there would be an assessment. Yes.
Yes.
I mean, the first assessment is, does it require further interrogation?
Yes.
Not everything gets to an IMT.
No, but
it's only the minority that do.
How does the level of detail and rigour that you've applied in each of these 85 cases in this case notes review exercise compare to the level of data extraction and rigour analysis that you would do in a group of cases that had got to that next level in your domestic system?
Well, I think if you're dealing with an infection in real time, an awful lot of your concern and decision making is the result of engagement with the microbiology and the infection control teams. So you have a discussion.
Yeah.
And so the microbiology team would come to the ward regularly. If there was a particularly unusual infection, the microbiology team would come very promptly and say, "Can we discuss this patient? This is."
And you'd have some sort of multidisciplinary team meeting, effectively.
Yes, I mean, but we didn't necessarily all go and sit down in a PAG or an IMT.
Right.
But we would would discuss it, and the microbiologist would give advice not only about the antibiotic treatment of the child, but the isolation of the child, and whether other precautions would or other investigations were required to understand better how this infection came about.
And so when you...
I'm so sorry, just to finish your question. So when you see a list of all this information put on a piece of paper, it's a much more rigorous process, because it's trying to go back and mimic the informality of that interaction in a retrospective manner, where you have to be much more prescriptive about, this is what I want to know.
And what level of comparison does it bear to, have you given evidence in litigations in your career over the years?
Yeah, I've given evidence both in a criminal setting and in a medical legal setting.
But in a medical legal setting, how does the level of detail and rigor required for a medical legal report produced by you on a particular child compare to the level of detail and rigor that you say you carried out in this exercise for each of the 85 children and their infections?
I perhaps I need to understand the point you're reaching. I suppose
I can advance it a little bit, which is that, in a sense, if you're giving evidence in a court setting,
yes,
as an expert witness,
yes,
not only you need to demonstrate that you are independent, that you are an expert,
yes,
that there is an external body of expertise
yes,
you can run, but you also need to show your workings, in a sense.
yes, yes.
This exercise that you have carried out with your colleagues, you aren't showing your workings completely.
Yes.
So in order for us to understand to some degree, to the extent that we can, or work out how far can we go, it'd be quite interesting to see if you were producing a report on, I doubt you've ever done this, but a report on whether child A has caught their infection in the hospital in a medical legal negligence sense.
Yes, okay.
If that report was being produced and you were required to input that as a hemato-oncologist, how does the level of analysis you say you carried out here compare to that level of analysis that would be required?
I think it would have to be the same. I think if you're looking at something as serious as, did this child get an infection from the environment in which they were being cared, then I think you have to be very rigorous in terms of the acquisition of data. If you're looking after a child with an infection on a day-to-day basis, because infection is a day-to-day occurrence in children's cancer care, then you're constantly adjusting and making judgments about whether this is unusual or not. And maybe I can illustrate that. Maybe it feels slightly off beam, but one of the things I did fairly soon after I started doing this work is I went to meet the infection control team in my own hospital and just said, can I just discuss with you, what this feels like? And and I talked about Stenotrophomonas, and I said there seemed to be an awful lot of Stenotrophomonas infections in this cohort. And I could only remember possibly one or two infections of patients with infections with Stenotrophomonas that I had treated. And I was really surprised to encounter the number of infections. And the response I got from them is, we almost never see Stenomonotrophus in bloodstream infections in this population of patients. So why do I use that example? It's because I think you always have to be alert to whether what you're dealing with is consistent with everyday practice, because we know children get gram-negative environmental infections during the course of chemotherapy, or whether it's something that's completely out with what is your experience in your own centre.
Because if there was a child who got a line infection,
yes,
while you're trying to push the numbers down all the time, that isn't in itself unusual.
No.
No.
I mean, if you consider how long children have little bits of plastic tube coming going into a big vein and coming out through the skin, it's not at all surprising that there is a degree of infection. All you can hope to do is to drive it to the minimum level possible. And by reflecting on practice and taking advantage of technical changes to dressings and so on, you can do that. And that's what GGC did in relation to gram-positives.
What I'd like to do now is to talk about clusters and sort of get back to probable, and we'll come to that, maybe not for the copy break. But again, looking at this Appendix D, this data collection exercise, where do we begin to see the context that's independent of the individual patient? The idea that there is another case a week before or a week after. Where does that information get collected?
If you were to go back to the diagram,
so that
our process, our process map. Well, actually, in fact, part 2. If you stay on that screen, I can explain it here. Just a third the way down, you see a shaded box saying Tableau timeline.
Yes.
So perhaps I need to explain that.
Miss Evans said something, but I'm interested to see what you say.
Okay. Well, so what HPS built for us was a really very effective tool, which essentially was an interactive spreadsheet. Every one of the 118 infections was listed, as it were, horizontally on the spreadsheet. And by child, so some children had more than one infection. So for each infection, what we had was a horizontal axis that went from May 2015 to December 2019. And across that axis, for every child, we had every encounter with the hospital.
So there'd be sort of coloured block.
Yes. Well, or a single line, because if it was an outpatient clinic or a day case appointment or an inpatient stay, it was represented on that horizontal line. So every single contact with the hospital was represented horizontally. And you could hover your cursor over that line and it would say 6A, for example.
Yeah.
And you could see that the child had been admitted to 6A on the 12th of September 2019 and stayed in 6A until the 14th of September 2019, and then went to the Pediatric Intensive Care Unit, for example. And then you could see how long they stayed in the Pediatric Intensive Care Unit. And overlying that, we also had the date of every infection.
In terms of coloured indicator or something?
Well, it was usually a cross.
Right.
And then you could hover over the cross and it would say Steatomonotrophus, whatever. And there was a selection capability, so I could go to this Tableau spreadsheet and I could say, give me all the Stenotrophomonases, or give me all the Pseudomonases, or give me all the Elizabeth Kingias.
And they would all be compressed down and just show that?
And then it would just show me the patients who had, or the episodes that had involved Elizabeth Kingia. That was a very short list. Stenotrophomosis, longer list, obviously. And then what I could do by looking vertically down the list is I could say, oh, well, there was an infection there, which was December 2017, and there was another one there, May 2018, in another patient. Or I could say, give me all the patients with enterococcus, and I could see that there were 6 of them within a 7-week period, or whatever it was.
So this is a visual.
So it's a visual thing. So it was a magical tool, quite frankly, in terms of our ability to relate dates of infection to dates of contact with the hospital and the duration of that contact with the hospital. And you could also map where patients had moved internally within the same admission.
Right. So that obviously the origin data behind that is GGC data, but the work was done, you understand, by HPS.
Yes.
And how is that presented? I mean, we just got a white box, as you just admitted.
Yes.
Would that be narrative text or a little picture of the spreadsheet, or what would you find there in each case?
Well, it would. it would be narrative text, and the reason I'm just reaching for my notes is that I've got one of my worked examples
Right.
here. So that the first thing was that it enabled us to check whether the dates of admission and ward placement that we had identified from the case note review, I mean, pulling
Yeah.
the data out of the clinical record, aligned, and sometimes they did and sometimes they didn't. And I would sometimes go back to the team and say, you know, the date of admission seems to be incorrect, or you know, it says that this patient went to 2B, but in fact they were on 2A. And you know, and there were some miscodings. We found some patients who were still being coded to 2B even after the ward had closed.
Right.
You know, so it threw up these things. It obviously allowed us to identify and record the potential for clustering. And so when you look at the summary lower down in
The
this
next
chart
page.
that's on this, on this screen
Oh, right,
here.
right.
So Tableau timeline. So in the Tableau timeline, so let me, I mean, I don't think it's any breach of confidence. I can read out from my example case here.
Or maybe fudge the dates a bit, but yes.
Well, it says there were 8 Enterobacter infections in 7 patients in 4 months, from 28/4/18 to 28/18, and then it gave me, we listed all the patients.
Right.
So that we were able to go back to those records. Oh, and the patients' names weren't known to us; they all had a number.
Yeah.
So I was dealing with a patient, say number 75, but I could see that patient 13 had also had a similar infection on a date, and therefore I could go to patient 13 if I wanted, but I could also look at the Tableau and see how close.
So you could look at both your summary page for patient 13
Yes.
and the Tableau
Yes.
and bring it together.
Yes. Yes. And then we could make comments, you know, about that. But lower down under ICNet, telepath, IMT, and Pagments, we'd make similar comments. So under telepath, for example, for this same patient, I wrote for this patient, much discussion of antibiotic choices, limited by inability to use certain drugs. Notes indicate the samples were sent for both episodes for typing, but only results from the second episode are given, and so on.
And then the relevant parts of the IMT minute can be pulled into the next section, and then which we've heard from Miss Evans. And so is there anything else on this page that helps on the clustering issue?
No, I think the clustering issue was all under Tableau essentially,
Right.
because that's where we saw the clustering. I mean, that was a very useful visual tool. We could just see where they were.
So
otherwise, it would have been almost impossible for us to link these infections, except by rather tedious manual comparisons. But we could do it very visually.
Well, I appreciate it can be quite a tedious process to link all the dates. What I wanted to understand is, how do you deal with the criticism that, well, let's stop now and have a coffee break, and I'll come back to what does probable mean after we've had a short break, Lord. That's probably the best approach to it.
Okay.
Professor Stevens, as I said, we take a coffee break about this time. Can I ask you to be back for 10 to 12?
Of course.
Thank you.
Thank you very much.
Ms. McIntosh.
Thank you, Paul. I think probably what we should do before we discuss clusters in great detail, go back to the probability, the table of answers, as it were, on page 1043 of bundle 6. Yes, and so what we discussed, Professor, before the coffee break, unrelated, weak possible, possible, and strong possible. What I wanted to understand is, how does a infection get into the probable category?
Well, I think what underpins the probable category is that we've crossed the threshold that on the balance of probabilities, there's enough evidence to suggest that this infection is linked to the environment. So what takes you there? Well, what would take you there is if we had convincing environmental data that linked to the infection. But
So that might be a sample from the environment.
A sample from a drain or a tap, or that in the proximity of the patient. But as we made clear in our report, we really had access to rather scant information about water samples, certainly, and we didn't have any useful information. I mean, to shortcut it, I'd say we had very little useful information about maintenance on the wards, because it just wasn't coded adequately.
So would this mean you couldn't identify which sink was being cleaned, or?
Yeah, I mean, I think I did at one point look at ward 2A over a period of a month or something, and noted that the plumbers came maybe 15 times. I mean, really a significant, but you had no idea where they went. They were coming to fix a sink or a leaking shower, and I mean, these things happen in hospitals where we recognise that. One of the difficulties is then tracking, where that work was done. So what put patients into the probable group more often than anything else was, apart from the absence of other hypotheses like gut translocation, was it came down to a lot of emphasis being put on clusters.
So you've got whatever you can derive from maintenance records and from environmental records.
Yes.
And tests nearby. You've got the clusters, and we discussed the tableau.
Yes.
Is there a threshold in your mind about how much clustering you have to have, or how many environmental samples of the same species have to happen before it becomes a probable?
No, I don't. I think it would be. I think it would be disingenuous for me to suggest that we had a defined threshold. We looked at the pattern of the clustering. We discussed that pattern in relation to the nature of the bacteria, the likelihood that it could be found in the environment, where it was likely to be found, perhaps. Enterobacters and drains is something that it's not an uncommon correlation that you find enterobacters in drains. You find all sorts of things in drains, of course. But there were some quite striking, and it's evidenced in our report, there were some quite striking clusterings of patients over relatively short periods of time having the same infection.
Yes.
And then, of course, the hope that typing might illuminate whether they were related. And, again, as we made clear in the report, we did not believe that the typing information that was provided to us was actually that useful in terms of defining or refuting connection.
So I'm going to come back to the whole genome sequencing later. But if we look back at the table, we have a category of strong probable, which is sort of 3 of them have leaked out of probable in strong probable. What is it that's causing them to step up to the plate and be more significant?
I think it's probably I think it's almost certainly the emphasis placed on the clustering. It's does this clustering look stronger, more likely perhaps than in the other 30 cases, for example.
And if we go on to the next page, page 1044 and table 5.4,
Yes.
you've grouped together strong possible, probable, and strong probable into most likely.
Yes.
But a moment ago, you just described probable and strong probable as more likely than not. So there's clearly a difference between this table and more likely than not. But is there anything particular about the infections, the organisms that appear at the top of this table with larger numbers that seems to speak about clustering or grouping of events to you?
Well, I've already made a comment about the number of Stenotrophomonas in the whole series,
Yeah.
which is completely out with my personal experience.
In hemato-oncology, what?
Yeah.
What about Klebsiella?
Well, Klebsiella is certainly more common. It certainly occurs more commonly, but nevertheless, there were still a lot of Klebsiella septicemias, and although gut translocation with Klebsiella, I mean, these are enteric organisms, but the number struck me on an individual level as being relatively high.
I mean, when you say that Klebsiella is not as unusual as Stenotrophomonas, is that because Klebsiella as a translocation infection is not unknown, is a thing one comes across, or is it Klebsiella as an environmental infection is not unusual?
Well, I think I'm straying out of my area of expertise a little here, and my understanding is that Klebsiella is possibly not very frequently identified in water sampling.
Well, if I can bring you back inside your area of expertise and ask a question a different way, from the perspective of a hemato-oncologist,
yes,
when you see Klebsiella in your patients over your career, are you seeing it in the form of gut translocation type cases with the symptoms you described, or are you seeing it in a different context?
No, I think you see it in both contexts, but I suppose if I were to reflect on my own personal experience, is that it has probably more commonly been identified with gut translocation, but not always.
And how do you react to someone who, I mean, we see it actually in the GGC commentary that they sent to you on a draft, someone who reads this and thinks, well, look, they've identified 10 episodes of Klebsiella as most likely. That they're missing the fact that those quite often will be gut translocation. What is it you've done to ensure that those 10 cases aren't gut translocation cases?
Well, there are 18 cases of Klebsiella in all the other episodes.
So those are the ones that probably are gut translocation?
Presumably. I'd have to go back and look at them all.
That might well be.
I mean, I would have thought that was the most likely basis we sorted them out.
Right. So there's been an exercise in discriminating between the two.
Yeah, and I think actually looking at those two columns is quite helpful. There are 14 Stenotrophomonas in our most likely group and only 7 in the other. So the relative proportions of these organisms is possibly helpful. Pseudomonas, you see, there are only 4 in our most likely group. There are 13 in the other episodes because Pseudomonas and Klebsiella are probably the most typical infections you would see.
And when they're typical, how would they be coming about with a patient?
Well, I mean, sometimes you can have a patient who is apparently well, spikes a fever, you take a culture and you find that they're growing a Pseudomonas, and they can rapidly become unwell if they're growing a Pseudomonas. But or they could, and I said in the first session, I described a patient who had Pseudomonas septicemia not septicemia, Pseudomonas infections with raging gut toxicity. So
Yes.
you can spot it that way, perhaps.
So you would say, you're saying that the differentiation between these two columns illustrates that you've carried out a process to divide the two.
I think it does tell that story. I think the other thing about this table is there are some slightly unusual infections here altogether. Now, then they're not all in the most likely group, but Elizabeth Kingier is not an infection that it comes up in my day-to-day. It didn't come up in my day-to-day practice. Chrysibacterium. And so on. These are not Serratia. I would have encountered, but there's something about the pattern, and I think it's interesting that it's reflected in the unredacted HPS 2019 document, because there's a very interesting graph.
Well, I think we can probably go to that.
It's a sort of bar graph showing.
Yes, it's on page 233 of bundle 7. Now, I'm keen to avoid wandering out of your area of expertise.
No, but this is just a visual. I mean, if you look at this table, these are a distribution of the different organisms found in York Hill in 2A, 2B, and 6A and 4B, and one of the things to remember, of course, is that these periods are all very different. So this is a bar graph expressed as percentage, but if you look at the size of the component, so if you look at Stenotrophomonas in the first bar, you've got 4 cases at York Hill, but don't look at the number 4. Look at the size of the bar graph as it goes up of the Stenotrophomonas in 2A, 2B, and look at it in 6A, 4B. And you can see that the contribution of Stenotrophomonas to the distribution of infections has increased. The same for Enterobacter, quite
So
substantially.
you're saying that the proportion of what is a changing number of overall infections that's coming from Enterobacter has gone up.
Yes.
And even more for Enterobacter.
And this was, I don't know why this was redacted in the version of the report that we were given when we were doing our piece of work, and I only saw this when I was finally able to get the unredacted version. But I think it contributes to the story.
And what's the point it's making?
The point it's making is that it's not just the overall incidence of infections; it's the changing nature of the infections. You're seeing a range of very unusual infections, but you're also seeing infections that we know more about, but they're occurring more frequently.
So it's not just that there's the unusual stuff, which is, of course, the rainbow color at the top of the middle column.
Yes.
It's the fact that the sort of contribution to the volume from Enterobacter and Stenotrophomonas is strikingly larger.
Yes, and I think it supports what we said in our report, that simple observation of patterns of infection is as important as any other measure like incidence rates and SPC charts.
I wonder if I can just go back to page 1043 of bundle 6, because I forgot to ask you a question, put something to you. This was about possible.
Yes.
So we had some evidence from Dr. Crichton, who's now the Director of Public Health at
Yes.
Greater Glasgow, and she observed that a public health meaning of possible would mean that the features are compatible with there being this connection, but other diagnoses are possible as well. It's sort of more things are possible than just one. Why is it that your approach doesn't seem to consider the possibility of other causes? It's just this is possible. There's an environmental link here. Why have you defined possible this way?
I think our definition of possible was by excluding other reasons for the infection, really.
In your statement on page 131, paragraph 92, you discuss, we've obviously asked you about weighting of factors. And you've observed, I would not say that there was differential weighting in factors because the exercise involved considering all available factors in any situation. Our conclusions were not driven by the number of factors. Clustering is quite important. We didn't give formal weighting to one factor or another. We truly attempted to integrate our knowledge of the patient, our knowledge of the behavior of the individual bacteria in the environment. Some of these elements were complete. We used what we had. How would you react to the suggestion that what this is describing is, in effect, in some ways, a subjective assessment that is maybe an amalgam of your three expertises, but it's just, in a sense, it's your opinion.
But would you mind if I just answered the question about weighting?
Of course.
Because just to clarify that, I mean, it's entirely possible when you undertake a process as we did to say, well, we're actually going to, we're going to preemptively apply a weighting. So we're going to take evidence of clustering as worth twice evidence of gut translocation or something like that.
Yeah.
But we didn't apply any rules. So that's the purpose of paragraph 92, to say we had no pre-established rules. We just took the information, we tried to synthesize it and make a judgment. And I think we've been very clear in our report to say that this is our judgment. And a judgment is inevitably partly subjective. It's based on what you're presented with objectively. But in the end, you have to take and integrate and form a view on what you've got.
Which brings me to the questions of the limitations of what you've done, which you covered from paragraph 137 at page 145. Now, obviously, we can read what you said there as we'll read the whole statement. But if the inquiry's got to understand what weight to give to your conclusions in its thought processes, what would you consider to be the primary limitations of the work you're able to do?
I think the primary limitation actually was our inability to obtain data which would have usefully illuminated aspects of environmental exposure, either because it wasn't available or because when it was presented to us, we couldn't track the implications. So there are, I think we've given evidence where, a water report was said to be positive for Stenotrophomonas or another bug, but we actually couldn't find that in the data presented to us.
Right, because the data wasn't complete.
I mean, it was quite clear to us that there were challenges in relation to coding. The locations of patient care were often expressed differently, and I think I've seen that identified in someone else's statement. There were problems with dates. There were one or two occasions when the IMT said that information was available and we couldn't find it in the data set that was provided to us. Right. So there was a limitation, inevitably, that we could only work with the data that we were given. But what I hope that we would be able to convince you is that we used what we've got as effectively as we could.
I want to just pick up a couple of small things before we move on to the Health Board's response to your draft.
Yes.
So the first thing I wanted to pick up is we had some evidence from Professor Leonard on the 9th of October. During the course of his evidence, he discussed how the use of an antibiotic, meropenem, might have been the cause of later spikes of infections as a consequence of antibiotic resistance. Now, I've not shown you the data he used for that. I'm proposing to, but I just wondered, in the treatment of hemato-oncology pediatric patients, are the increase in number of infections in patients is something that can happen as a consequence of antibiotic resistance? And have you seen it?
No, I haven't seen it. I mean, all antibiotics convey risks as well as benefits, and the risk is principally the risk of inducing multi-drug resistance, multi-antibiotic resistance within organisms that respond to exposure to antibiotics by becoming resistant to them. I'm aware of a hypothesis that suggests that meropenem might drive the appearance of Stenotrophomonas in particular. I have looked at the literature, but I have to say I haven't done a robust literature review, but I have looked at the literature. I found very little that addressed that specific point. The most recent thing that I read was an abstract of an investigation looking at Stenotrophomonas pneumonia, which isn't necessarily the same thing as bloodstream infections, where patients who grew Stenotrophomonas in their sputum had got a greater, they had had a previous exposure to meropenem more than patients who didn't grow Stenotrophomonas in their sputum. The trouble is that this was an abstract presented, I think, at a scientific meeting. There's no detail, and these are adult patients. They may have had many other morbidities. I have no ability to say how relevant that observation is. I did see another paper, which is somewhat older in the literature, that said that there was no evidence that meropenem drove it. And then just to add my own personal experiences, that a meropenem regime formed part of our approach to empirical antibiotic therapy in my own unit in the past, and I've already said to you that we almost never saw Stenotrophomonas. I mean, that doesn't.
No, I suppose I can take to the last point from it. Your experience is that whatever's been going on in Glasgow in your unit, using meropenem as part of a treatment plan for a number of patients, hasn't generated peaks in Stenotrophomonas.
And I suppose the other reflection I would make is that if you were using meropenem for say as your primary antibiotic schedule for say 2 or 3 years, because all units change their antibiotic schedules in time in response to the sort of local flora. But if you'd been using it for 2 or 3 years and it was driving Stenotrophomonas appearance, then I think you'd expect to see Stenotrophomonas appearing fairly regularly, not in surges, which is what we saw.
I think you've already answered that question, so I don't need to answer it. Right. I suppose this is a question you've answered, but I think I should give it to you cold so you can give a complete answer to it. We had some evidence from the medical director of NHS Greater Glasgow, Dr. Armstrong. So it's for my colleagues, it's column 212 of her transcript, where she noted that I think this is just she's speaking, so this may be slightly misphrased. This next sentence, that 70% of the cases were possibly or probably related to the environment, and of course it's possibly is driving the 70%, but and it's not clear, she said, how you reached your conclusion. Am I getting the impression that you'd sort of, at some level you'd accept that because you haven't provided the 85 individual reports, or would you not?
I think presenting the data in that manner is unhelpful, because the key message from our review was not the 70%, but it was about the figure of around 30% of the most likely. Right. And that was in fact, interestingly, when the review was first published, that was the figure that was seized upon. And I'm rather surprised to hear the medical director reflecting it as a 70% figure, because I don't think that would be the interpretation we would seek to give.
But what I was pushing is, how do you respond to her observation that it's not actually clear how you reach your conclusion, either conclusion, because the data isn't, the narrative of how you reach this conclusion isn't fully available to the health board?
Well, I suppose I'm sympathetic to that. I mean, we started early on with you asking me about who had access to this information, and I suppose there is a scenario in which all 80 odd, well, it would be 118 actually,
Yeah.
data syntheses are provided and could be pored over and interrogated and challenged, and I can absolutely believe that if you gave 118 essentially RCAs, which was what they are, we agreed on that perhaps, and gave them to another group, there wouldn't be unanimity in terms of the outcomes. But that brings me back to my point that we were very clear that in the end we had to use our judgment in relation to data that was presented to us, and that's what we did. And I can understand the frustration of GGC not having seen the, as it were, the raw data. My challenge, however, is that they could have done this themselves. Why in 2020 were we asked to do this when they had been struggling for the best part of 5 years with a background of unusual and increasing infection? And and this is a question that we raised. I mean, we recommended root cause analysis in our report. One of the responses is that we're doing root cause analysis, but in fact, there were only 2 root cause analyses done in 2019 in the era of our review.
There wasn't a retrospective exercise carried out by the health board.
Not to my knowledge. The only thing I've seen is I think we saw 2 root cause analyses that were done in 2019, and I think there was an onward application of RCA methodology thereafter.
I mean, we've had some evidence about that. Right. Yeah. Okay. So what I want to do is to deal with the process of how you dealt with your draft. GGC responded to your draft, and ultimately pick up the letters and the meeting with the chief executive.
Yes.
And then we'll come back to whole genome sequencing and some issues about comparative epidemiology. Just seek to effectively get some information from you about different hospitals in the UK.
Okay.
Probably end up with that after lunch. Now, what I want to do is to go initially to back to your statement to page 143. Now, you describe at this point having a meeting with the chief executive following your draft report. Now, what I want to do is just laboriously, slightly connect the dots. So your draft report is in bundle 25, document 2, page 45. And if we slip onto the sort of second page, or even the third page, fourth page, we see that you've numbered the lines.
Yes.
So who received this draft report and when was it sent?
All stakeholders, we defined as stakeholders, received this draft report. Fundamentally, it went to GGC, it went to the Oversight Board, it went to HPS, and I'm not sure it went anywhere else.
Right. It didn't, for example, go... To whom did it go in GGC?
Almost certainly it was sent via Elaine Van Hagen, who was the conduit for our communications with them, certainly latterly. And who indeed was very helpful. But it must have ended up on the desk of the chief executive.
Right. And then they provided a response, or line by line?
They provided a very extensive response, line by line, with a lot of additional papers.
And then you produced a document that has those responses and your comments on them. I'm assuming that's some sort of large Teams meeting between the three of you doing those.
Yeah, it was a sequence of meetings.
Right. Now, if we can look at that document, that is also within bundle 25. It's document 5 at page 157. Now, I'm not going to go through all 70 pages because we'll be here forever. But I wanted to first understand is what did you understand the purpose of giving Greater Glasgow, Clyde Health Board and your other stakeholders the draft was?
We were very clear in our covering letter that we were inviting comments on points of accuracy, factual accuracy. We anticipated that there would be a wish to push back on some of our conclusions, and so we were clear that we really only wanted their view on things that they thought were wrong or that they had reason to believe were wrong.
What about, and there are a few in here, and we might go to them, points of disagreement about your methodology? Were you expecting to receive those at this stage?
Yes, I think I probably was expecting to receive quite a lot. And, it's a bit of a moot point as to whether that's a factual inaccuracy or not.
Yes.
And, I was, it was quite a challenge to us because we were working to a very tight deadline at this stage. And for us to process this very substantial document with, I think there were 28 embedded documents within it. I mean, it was a pretty substantial piece of work on their part too.
And how would you respond to the suggestion that they really never got an opportunity, that is the health board as an organisation, to input into your methodology?
Well, I can understand that that was their perception, but the reality is that we were an independent external group appointed by the Scottish Government to do this piece of work. So there is no particular justification in my mind to ask the organisation that we were looking into from this perspective to comment on our approach.
Had they wanted to do that, when should that have been done? When should they have commented if they wanted to comment either to you or anyone else? I mean, your methodology is something that you've described this morning as a root cause analysis multiplied by 85 or 118 times.
Yes, in broad terms, yes.
And you've described going to a series of meetings in January to collect information, a single meeting around table before the pandemic puts you all virtual, an epidemiology document that, cutting short, you didn't draft, it's come from somewhere else, and your main what you wanted was a shopping list of your data sources. We will come to in a moment suggestions that you should have done comparative exercises, that you should have included certain principles and not included other principles. When were those decisions made to do it that way, and how could GGC have influenced that process?
I don't think they had an opportunity to influence the process. Whether they had an opportunity to influence the cohort, I don't know, because essentially the cohort was presented to us, but fundamentally the cohort was based on the HPS 2019 report.
And they've used the HPS 2019 work to support their position. So
they have, and so I'd be surprised if they were critical of the choice of the cohort. They didn't have an opportunity to comment on our methodology because, of course, had I written down our methodology in March 2020, it would have been a rather slim account compared to what's in the final case note review, because essentially, we evolved in terms of the approach we were taking, the amount of information we wanted, the necessity to look in detail at IPC policies and processes and audits and so on. So these things evolved as our understanding of the issues took place. And then we needed a bit of time to just get a few of these reviews under our belt so that we actually had an understanding of the shape of the data we were getting.
Yeah, I'll probably pick it up at the end, but let's just walk through some of these ones. What I want to do is first go to the next page. So do you see how at line 127 they've referenced their public health commentary?
Yes.
Now, I want to talk about the public health chronology, and so I'm felt it was probably important to jump to that, and that is in elsewhere in bundle. It's in bundle 27, volume 6, at page 310. Now, this was prepared by Dr. Crichton, and she's given evidence about it being asked to do it at short notice. I think it's probably fair to say that it contains a number of suggestions about methodology, and I'm conscious that you're a hemato-oncologist, not an epidemiologist. But I think probably the thing to do is to firstly pick out the second comment, which I appreciate it's not your response, it's Mark's response, but I didn't have time to ask him this. Was there any discussion in your work as a group about doing a comparison with other units?
Only in acknowledging that that work had, in a sense, already been presented to us in the HPS 2019 report.
Right.
But I think there's more to the 2019 report than that.
Yes, because I mean, Greater Glasgow and Clyde seem particularly interested in drawing our attention to the section that deals with the comparison with Aberdeen and Lothian. But other than that discussion, did you discuss amongst the three of you, why don't we compare the rates with, say, Bristol or Leeds?
No, I don't think we ever had a material conversation about undertaking that, because I don't think that was truly reflected in our terms of reference. But the rate of infection is important, clearly, in terms of the overall risk of the population. But we were being asked to identify whether individual children who had already acquired an infection were likely to have acquired that infection from the environment. So we weren't really being asked to comment on the rate of infection, although had we had information, as I've subsequently seen in expert reports from Mr. Mukherjee, which showed the order of magnitude of the rate of infection being so much greater in Glasgow, and I know there are aspects of this that are disputed, but the order of magnitude of the rate of infection being so much greater in Glasgow than in other units, I think it could have added weight to our concern about the environment. But I don't think
we'll come back to Mr. Mukherjee after lunch. But the 3 points made in here, the second one that seem important. The second one is they mention in the paragraph under. If we count them down, 4 paragraphs down, we have the comment about comparators, and you've mentioned the comparator units, and I discussed that yesterday with Ms. Evans. Mm-hmm. And then we have the Aberdeen-Edinburgh comparison, which is mentioned. Then there's discussion of causality and the Bradford Hill criteria. Now, I'm conscious that you're not an epidemiologist, but to what extent did you think you were applying some form of epidemiological test in the carrying out of this root cause analysis?
Well, I think from the outset, I think we were clear that the basic premise was the time, person, place algorithm, as it were. Mm-hmm. I was a little surprised when I saw this reference suggesting that we should have discussed the Bradford Hill criteria. The Bradford Hill criteria are embedded in epidemiological practice, and I suppose I didn't feel there was a need to particularly comment on them. I thought it was implicit. I think that would be my response to that. And in fact, the reference they gave us wasn't particularly illuminating. But, and I'm not an epidemiologist, say, and I know that what Bradford Hill described are some important principles, but it's not a checklist.
Right.
It's an approach to considering a set of circumstances.
And then, again, you're not an epidemiologist, but there's a discussion about use of statistical methods and the clustering illusion. The way you've described this exercise is a series of individual exercises repeated as the new data came in. Is there not a risk that you are creating a self-fulfilling prophecy, that you keep discussing the cases because you see there's a cluster, that gives you a reassurance that there is a cluster, that means you're more likely to categorize it as probable, and effectively you're creating something artificial out of a chance event, just because the way human minds work. And therefore some form of statistical checking might have been a good idea.
Well, I suppose my first response to that is the cluster was a reality to us. It wasn't a construct. I mean, we could see where there were periods of, if you drew a heat map, you could see where there were periods of intensity in terms of infection. We could see that on our Tableau timeline. So the clustering was a reality, and so it was inevitable that we were going to reinterpret sequential patients in that context. But not all patients had infections that were brought up in the context of a cluster by any means. So it wasn't something that was applicable to every single infectious episode. I mean, it was still selective. The statistical thing is a little bit more difficult, I think, because the statistics, I mean, the suggestion of indirect standardization, it relates to a statistical technique for comparing two populations.
Yeah.
And indirect standardization is where you don't have a complete data set for both populations. So you can use a reference population and by which you can look at the rate of something happening in a second population and saying, well, compared to this reference population, it's more than you'd expect or less than you'd expect. But that takes us back to this whole issue about calculating incidence rates, which we felt that HPS 2019 had made an attempt to do, and I didn't know there was another data set available for us to do that. Nor did I think that it was actually our primary responsibility to do it.
Because you were driven by the actual individual cases and analysis of those.
Well, I think we were driven by our terms of reference, which is, what is the likelihood that these 84 children and their 118 episodes of infection derive from the environment or not? And knowing that there was an overall increase in infection rate in the Glasgow cohort would, I suppose, have shone a stronger light on it. But I don't think of itself it would have changed our observations. It wouldn't have told us whether it was a possible or a probable or a definite.
If we go back to the discussions that were going on in the IMT in the second half of 2019, we've heard evidence that there is a suggestion, the recommendation from Professor Leonard and Professor Jones in September that the ward is microbiologically safe. At that point, there is some pushback from the nurse consultants who are attending. There's a series of further meetings and work, and eventually there's a video presentation in November and an acceptance by HPS that the ward is microbiology safe and it's open to new patients. And during that period, there's a lot of data produced, including data produced by Dr. Kennedy and within GGC, and a presentation is produced. And HPS isn't the only source of data. And one of the observations that seems to be made is that there isn't a distinction in the rate of infections then in 2019 between what they are in 6A in 2019 and what they were back in the old York Hill. And that's one of the factors that's used to make the decision to reopen the ward. So there were other sources of data, but you didn't have access to those.
No, and I to be fair, I don't think I I was aware of all that narrative. There were two things I was aware of. One is there was an SBAR produced at the end of August, I think, in that year,
Yes.
which I think was very clear that it didn't think the environment was safe.
Well, that was produced by the former lead ICD and one of the microbiologists.
I understand, but that's one document I saw. The second document brings us back to the HPS 2019 document, where I think there is a very important distinction between the redacted and the unredacted version.
And that's this graph that we just looked at.
No, it's a sentence in the report which was removed in the redacted.
It would be helpful just to look at that. So we go to bundle 7, I mean, I don't know whether you can find it for me because it's a distinction I haven't spotted.
If you look at summary and recommendations of,
that's page 235, please.
and are we looking at the redacted
This
or
is
the
the unredacted version.
So the unredacted version, which is ostensibly the version that was first produced in October, says, if you go to the very end of summary and recommendations,
The next page.
There's a series of dashes here.
Yes, on page 236. There's someone doing transcripts here, so I have to read out pages and things.
I think this is not the redacted.
This is the unredacted
This
version.
is the unredacted. Okay. Well, if you look at the unredacted version, the fourth bullet point from the bottom reads, NHS, GG&C should consider the data provided in the context of the findings from the action plan.
Right, and if we
And
go...
then under that,
Yes.
it says, NHS, GG&C should consider current control measures around restriction on services for newly diagnosed patients. Now that's the key statement. If you go to the redacted version,
Yeah, I'll just get you a page reference. Well, the version we've got is page 272. Doesn't have any. It's not different.
yeah, it is actually,
it is,
with
of course,
respect. It says, the fourth bullet point from the bottom says, NHS, GG&C should consider current control measures around restriction on services for newly diagnosed patients, as there is no evidence from the HPS review of the data that supports the continued restriction of services. So from the time this report was produced in October 2019 to the time it was published in apparently November, although it's still dated October, there has been the addition of this sentence.
So the timings for that would mean that would be around the time of the discussion about whether the ward was to be reopened. So what do you draw from the distinction here that you now become aware of?
Well, I suspect there was a challenge to the message of the 2019 report from HPS, which, I think I've written in my statement. I don't believe the HPS 2019 report actually offered universal comfort to GGC about the safety of the environment.
And that's related to the issue around the comparators or the general results, as it were?
Well, we've already looked at that diagram where I was pointing out the change in proportion of Stenotrophomonas infections, which was redacted.
But also, would this also be referenced to, if we go to the unredacted version, to page 229? It'd be this figure 4, perhaps, or?
No, these figures haven't changed.
No.
Although I think for some reason some of the y-axis measures were redacted. I don't understand why. But I think the SPC charts are fundamentally the same.
What is the thing that you see in the data and the analysis, as opposed to the conclusions, that is not entirely positive about this report?
Well, I think, my critique of this document, I don't know if you wanted to take me to SPC charts at some point, but...
Well, there is a general critique of their use, and I understand that. I don't think we need to revisit that.
Okay.
But in terms of, if we can take what's in your statement as slightly as read, what would you list the things that are unhelpful in this report?
Well, I think it's the appropriateness of the SPC charts in this setting is one. The second is that it's clear to me in retrospect, and I didn't realise when I first saw this report, or 3 or so years ago, that the comparison with Aberdeen and Edinburgh, I think, is inappropriate because
So that's on page 231.
Yeah, it appears that this was a whole hospital comparison of data. If you look, in fact, it says comparison with other health boards when comparing the overall hospital rate of positive blood cultures. So it seems to me that this was not a comparison of the hematology oncology patients in these 3 hospitals.
Right.
It was a comparison of whole hospitals.
That's the whole children's hospital.
Well, that's what it appeared. Now, I did want to discuss with HPS. I did want to try and clarify this, but I think probably it was inappropriate for me to ask them to clarify it. But
well, I think the evidence that we had, if I recollect, and we can check the transcript, was that one of the difficulties around carrying out this work was it was done at very short notice in a 10-day window, and it's quite hard to get data.
Yeah, absolutely. It is very difficult to get this kind of data, but you see, I just think that, and then the second thing is that they pooled the 2 hospitals. The profile of the 3 children's hospitals in Scotland are very different in terms of their size and complexity of case mix. Aberdeen has a very small paediatric oncology unit. Edinburgh has, by UK standards, a small paediatric oncology unit. Glasgow has a substantial paediatric oncology unit with a bone marrow transplant unit. Then it's not the same case mix.
And so it's not comparable.
Well, I mean, in the end, in life, you compare things with what you've got, not with with what you hope you might have. But you have to bear these things in mind. So I think there was a rather, perhaps it's a bit unkind to say, casual assumption that these comparisons were comforting, and I'm not sure they're necessarily valid enough to be comforting. The other point, of course, is it says that the rate of positive blood cultures was higher in Glasgow for environmental, including the enteric group, over the 2 years, 2017 to 2019, and the overall rate was higher throughout the period. I think if you look at the paragraph above.
Yes, so it reads, the incidence of positive blood cultures, it's in the middle of page 231, using the case definitions 2 to 5, was higher in the RHC for environmental, including enteric group, but lower for the gram-positive group, and there was no difference in the rates for the gram-negative group and the environmental. And then compared over 2 years, the rate of positive blood cultures was higher in the RHC for environmental, including enteric, and the gram-negative group, but lower for the gram-positive group, and no difference in the environmental group. What's the point that you would draw out from that?
Well, there were actually differences.
Yes.
There were actually differences, but the conclusion seems, and it's stated, I think, in Jane Grant's letter that there were no differences, and I think it's just not the case. I think there were some differences. You can debate the degree and meaning of the difference, but it seems to me that this report was interpreted less precisely than perhaps it should have been.
Right. Well, I'd like to go back to the reaction to the draft. So that's bundle 25, page 159.
If we're,
Unless it's
Mr. McIntosh, if we're
back to bundle 7.
If we're moving from the distinction in the conclusions between the redacted and unredacted drafts, I think I'd like to ask a question.
Of course, I'm in your hands.
Professor Stevens, you've pointed to a difference in the wording between the unredacted draft and the redacted draft. Now, if I've got them the right way around, the redacted draft is the one that comes after the
Well, I understand so.
Yeah,
The redacted draft is the one I only ever had access to, and I could never understand why.
I have to admit, I don't think I've necessarily been aware of the distinction between these two texts, and I may have been looking at them thinking I'd been looking at the same document. However, if I've got this right, in the redacted draft, there is additional text Have I got that the right way
Yes,
around?
yes.
Now, what significance do you draw from the addition of that text?
Well, the additional text reads, there is no evidence from the HPS
2 to
review of
6.
data that supports the continued restriction of services.
Mm-hmm.
And I would just challenge that statement. I think that
Right.
the unredacted version is without that statement is a more honest understanding of what this paper was all about.
There may not be much a distance we can take this. I have to admit that when I read the unredacted version, although it doesn't say it explicitly, I took the meaning from that was that you should look at your restrictions again because they need to be looked at again. The implication being that the authors of the report were unconvinced of the necessity of them. Now, that's simply my reading of text, and it may be wrong. But you see a distinction that the addition of, I do see the addition of text makes the position explicit. I just would invite your comment on whether that meaning was not already implicit in the unredacted draft. It may be an unsound observation, but that's a different point.
I think I say in my witness statement that that I didn't think that GGC should have taken as much comfort from the HPS 2019 as they appeared to take. Mm-hmm. And then when I discovered, and this is a long time after I did my witness statement, that there was this changing in wording, it seemed to me it was just pushing that observation to a slightly more stronger position.
Thank you.
I suppose what I should probably put to you is that the evidence that we've had from those involved in the events of September, October, and November is that there is a change of position in HPS. They move from being unconvinced about the ward being suitable for reopening to accepting that. And that is a decision that's then made in November. And so you haven't seen the other information they were looking at. You're just looking at this.
I'm in no position to speculate why there was the change.
You're just noting
all I'm
it.
doing is I'm pointing out there was a change.
What I want to do is, before lunch, is to look briefly at the subject of Mycobacterium chelonae, and I wonder if we can go back to bundle 25 to page 159, the top entry. So we probably don't need to go to the paragraph, line 292, but in your draft, and indeed your final report, you state there were 3 Mycobacterium chelonae cases, and you get this comment. We consider this statement to be accurate as we believe there should be state 2 patients, not 3 per cases reported in the IMT minutes. Now, I want to be able to see if this is a bit of a memory test for you, so maybe you may want to go away and think about this, but which year can you remember are the 3 cases of Mycobacterium chelonae?
I think you could probably find it. I can't answer it, but I think you could probably find it from our overview report.
Right, well, let's go look at...
Because there's a table which gives you the distribution of infections by year.
So that's bundle 6.
I've just got to find the page.
No, I'll find it. Page 1028.
Two in 2018 and 1 in 2019 is the answer.
So the reason I'm pushing this is table 4.2, and it appears on page 1029. You've got, this is at genus level, you've got 1 in 2016, 2 in 18, 1 in 19, and then at species level.
So I've got 4 there. But one patient had 2 positive cultures.
Well, indeed, and that's the thing. I want to look at page 1030 if possible, because I think our experts might have worked this out independently, and I wanted to just see if you could recollect something. So do you see you have at page 1030, 2/3 way down the page, Microbacterium 1 case in that column, which is 16, 2 infections in 18, and 1 in 19.
Yes.
Now, the patient who has the 2 infections in 18 is known to the inquiry and is a core participant. The patient in 19 is not a core participant directly, but we know of. The patient in 16 is quite interesting. How did you find it?
It was in the data set presented to us.
It wasn't added in because they were the Microbacterium cheloni.
No, I mean, no.
It was in the bloodstream infection data set.
Yes, I think one case of Mycobacterium chelonii was not a bloodstream positive case. It was, I think, a pus-derived culture. I think.
Because the reason is that Dr. Mumford has in her report identified the 2016 case from the bloodstream infection samples that we supplied to her. It appears in a footnote in her narrative. I don't know whether you noticed that.
No, I didn't.
No, but the reason I wondered if you'd be able to work out why the health board thought there were only two patients affected.
I don't know. I could try to go back to original records and.
Why you don't have access to them?
I don't have access, but I do have access to a certain amount of data. I don't have access.
I don't think there's any dispute about the fact there was a 2016 case. That's not the point. It's that I wondered if you were able to tell us more from your engagement with the health board about why it was that they thought there were only 2 patients affected.
I've no idea.
Right.
I've no idea. I mean, I just assumed that they'd made a mistake. I mean, we just said we disagree. There are 3 because we dealt with 3. We knew that.
Because that's the records that you were seeing.
Yeah.
Right. I wonder if we can go back to bundle 25. Go to page 162. This comment about the pediatric trigger tool. Was this the first time you'd realised there's some anxiety in the health board about its use? Or had it come up as a problem before? Because it eventually results in letters and things.
No, I mean, when I first met the hematology oncology clinical team, that was front and center of their concerns.
Right.
They said, why are you doing this? Why are you using this technique? I was slightly disarmed because, as I've already explained to you, I didn't particularly want to do it.
Right.
But I didn't know there was a board level anxiety about it. I think they wanted to know about I can understand why they wanted to challenge the validation of any methodology we were using, because they've challenged all the methodology we've used, and they just wanted to know. And I mean, that's our descriptive answer. This didn't strike me as a particularly significant encounter.
Right. Can we go just briefly to 167, which is line 1206, 1220. This is discussion about the comments from the health board is in this 3rd column. Terms normally in clusters are undefined. They're commenting, they're drawing out the conclusions, they say, of the HPS 2019 report. The data presented in this report does not provide evidence of a single point of exposure, and there is a need to continually monitor the risk of the patient population. Now, you provided your response to yourselves in there. I just wonder what your reaction to the idea is that you're looking for a single point of exposure. Is that the question you were asking yourselves, or?
I mean, I suppose it's I suppose I'm slightly confused. It depends what you mean by a single point of exposure. Was it a single tap in the whole institution that was the cause of a problem, or was was there a more generalized point? I mean, we always took the view that it was very unlikely to be a single point of exposure. That there was a more general risk for the environment.
Because one of the things that we've noticed in the evidence from those involved in the IMTs, of course, you didn't speak to the actual clinicians about the substance. It comes from the notes in your case. All your knowledge comes from the IMT minutes rather than taking witness statements or anything.
Yeah, we didn't take witness statements, no.
So we've had some evidence that there's a view that's not held by everybody.
Yes.
That in 2018, the source is the water system systemically or widespread, and it involves biofilm, and it's happening across the whole hospital, and that results in point of use filters and chlorine dioxide. But in 2019, there's a discussion of other things. The drains have been an issue the previous year, the chill beam systems, condensation on them, and also leaks from the chilling circuit. Now, all of that begins to bubble up in 19. And one of the things I've noticed about your report, I just want to pick this up before the lunch break, is that you don't really discuss what the environmental causes are, other than just the environment in your report. Is that a deliberate step?
Yes, I think it was, because we were aware that this was a recently evolving understanding, and we felt that our task was to look as widely as we could at the environment in terms of seeking information.
Yeah.
So we were looking at IPC practices, we were looking at building interventions, we were looking at water sampling, we were looking at what we called hard surface sampling, which included drains and chill beams. We were trying to go to every place without kind of having any a priori understanding of what was likely to be the source.
Does that mean that your conclusion, if it tells us anything, is that there's a 30% or so of the infections have a probable or more than likely than not, whatever it is we've discussed, connection to the environment? You can't tell us precisely what the causes were. You can't differentiate between chill beams and the water supply and the individual.
No, I don't think we. I don't think we can. But I think what's emerged since we did this work is, in my understanding, is anyway that the water system was contaminated, and so my assumption is that supply had something to do with this, but
that wasn't a conclusion that you reached directly.
No, and I don't think you'll find that we put anything to that extent in our report. I don't think we did.
Because one of the things I realised I should have asked Miss Evans yesterday, and I can't ask her now, so I'll ask you before the lunch break, is that I put it to her that, in a sense, your exercise was a bit like an IMT.
Yes, I think it. Essentially, it was. I mean, my understanding of an IMT is it takes something that's been flagged within a PAG as significant or serious or whatever you like to call it, and it seeks to look in the round at what's going on, whether it's one particularly serious infection or whether it's a run of other infections. And the purpose of the IMT surely is to try and illuminate what's going on, because if there's a remediable cause, then you need to do something about it.
But the distinction between your exercise and an IMT type system is that you're not actually drilling down to sort out that sink. It's the water, it's the chill beams. You're leaving it at a more broad, it's the environment.
Well, I think we were trying to do that. So I think when we asked for records of water samples and hard surface samples and so on, at the start of this, we rather assumed that we would get a stream of information that might inform that. And it was only when we looked at the data and began to say, well, we can't see anything here.
But you didn't, in your final overview report, say X percentage of the probables are connected to the water system, Y connected to the
I don't think
chill
we were
beam.
in a position to do that.
No.
I mean, there just wasn't any data to be able to direct us in that way.
Okay, well, that's very helpful. I mean, Lord, I suggest this is probably the right time to pause for lunch.
Yes, we'll take our lunch break, and could I ask you to be back for 2 o'clock, Professor?
Certainly, thank you very much.
Please stand.